It's my great pleasure to announce Judith Balmana. She's an oncologist, clinical oncologist, working in Barcelona. She's also part of the ERN Gentouris. That's the reason why I asked her to give a talk about therapeutic relevance of germline mutations. Judith is online now. I can't see her. She can't see me, I guess. I don't know. Judith? She's in outer space.
Yeah, can you hear me?
Hi, Judith. Welcome.
Hi. Thank you.
It's all a little weird coming from outer space. Okay, Judith, many thanks for taking part in this symposium and giving us a talk about your special field of interest and knowledge and education, therapeutic relevance of germline mutations. Many thanks. The floor is yours, Judith.
Thank you, Elke, and guten Morgen to everybody. I wish I could give the talk in German, but unfortunately I'm not able at this time. So I will present my talk based on a clinical case. And so let's start with a 48-year-old male with no past medical history, who presented in clinics with an anemic syndrome, with an hemoglobin of 11, and a fecal occult blood. He had lost 7 kilos of weight. And in the colonoscopy, a flat polyp of 10 millimeters was identified in the rectum, and then also multiple bloody feces in the right colon. The gastroscopy showed an ulcerative lesion in the duodenum, and the CT scan, as you can see now, a very big hepatic lesion, which you can see in here. So some samples were obtained in the duodenum. A high-grade malignant tumor suggestive of mesenchymal origin was reported, and the polyp in the rectum was a sessile tubulobulous adenoma with low-grade dysplasia. Then the liver lesion was also biopsied, and this was reported as hepatic metastasis of a melanocytic melanoma. Looking a little bit further, there were no BRAF mutations, there were no KIT mutations. Hemoglobin went down to 9.5, and LDH was very high, 3,000. So here we have a patient with a duodenal melanoma, BRAF wild type, stage 4-3, with LDH doubled. So very bad prognostic factors. And he was recommended to start first treatment with immunotherapy with nivolumab and ipilimumab, followed by maintenance with nivolumab according to Checkmate 067. He started in March 2018, and that's the evolution that we can see. That was at baseline, this was at 6 months, and this was 1 year. The patient has achieved complete response. He's doing incredibly well with a good quality of life, and he remains free of disease 5 years later. So my question to the audience is, what has made this patient so sensitive to immunotherapy? What would be your guesses? So let's start with his family history. We can see in here on the left, this is our patient whose father was healthy at the age of 79. He had an uncle with colorectal cancer at the age of 86, a first cousin with colorectal cancer at the age of 60, endometrial cancer age 71 in his aunt, and then another cousin who had endometrial cancer at the age of 56, breast cancer, and bladder cancer. This patient had previously been tested in another hospital, and we will see what she was found. But going into more detail on his pathological report of the liver metastasis, immunohistochemistry of the mismatch repair proteins was performed, and he was found to have loss of expression of MSH6 spread in dots. When doing the microsatellite instability, his tumor was nevertheless microsatellite stable. And he underwent germline genetic testing and was identified a pathogenic variant in the MSH6 gene. that was shared with his cousin with endometrial cancer. So in conclusion, we have a male patient with a melanocytic melanoma on Lynch syndrome, with a germline mutation in MSH6, with loss of expression in dots, microsatellite stable BRAF wild type, who received immunotherapy and who achieved a complete response and is free of disease 5 years later. So what makes these patients so sensitive to immunotherapy? So let's just review a little bit the mismatch repair model for carcinogenesis, knowing that the mismatch repair genes are a part of a repair pathway of mismatches that occur between bases and also insertions and deletions in pairs, that they tend to happen usually in microsatellites, which are some long sequences of repetitive nucleotides that might happen in mononucleotides or dinucleotides or tetranucleotides encoding regions of some genes. And instability of these microsatellites may lead to frame shift mutations encoding genes implicated in tumorigenesis, and therefore cause a susceptibility mainly to colorectal or endometrial cancer. Mutations in these genes may translate into loss of expression of the protein, as you can see here in this immunohistochemistry panel. So how common is microsatellite instability? In a very big study done in the cohort of the Memorial Sloan Kettering Cancer Center with more than 15,000 tumors, MSI was analyzed in all of them, and approximately 2% of these tumors had high microsatellite instability. As you can see here on the left, colorectal and endometrial cancers were mostly MSI high, but also tumors of the small bowel were the ones who had the highest proportion of MSI high tumors. And you can see here very well the causes of this mismatch repair deficiency that could be related in orange to mismatch repair germline mutations, or that could be related with other epigenetic regions, such as methylation of the promoter of MLH1. Interestingly, when looking further into the germline analysis of these patients, among the cohort of patients with microsatellite instability, 16% of them did have a germline mutation, and therefore they have Lynch syndrome. This prevalence decreased very much in patients with MSI indeterminate to 2%, and was very, very low in patients with microsatellite stable tumors with only 0.3%. Nevertheless, when looking down, spread by the different germline mutations, what we can see regarding MSH6 is that a quite proportion of them might be tumors that do not have microsatellite instability, and they are being presented as microsatellite stable. Therefore, performing both immunohistochemistry and MSI analysis in tumor samples might be very helpful in order to differentiate or identify the ones that potentially may respond to immunotherapy. So in conclusion from this paper, we learned that 50% of Lynch syndrome patients with MSI high had a tumor not previously associated with Lynch syndrome, but thanks to performing this molecular screening, they were lately identified, and that 45% of them also did not fulfill the classical clinical criteria for germline genetic testing of Lynch syndrome. So here we are with a new avenue and a new scenario of another pathway to identify patients with Lynch syndrome. Interestingly, these patients, as had been shown in 2015, may respond very well to PD-1 and PD-L1 blockade. In this seminal paper, 13 patients with mismatch repair deficiency were treated with immunotherapy. 85% of them did have Lynch syndrome. 25 patients were mismatch repair proficient, none of them had Lynch syndrome, and 40% of the patients had a mismatch repair deficient non-colorectal cancer. They were all treated with pembrolizumab in this phase 2 clinical trial, and 62% of them colorectal metastatic patients with microsatellite instability achieved a response rate, 0% among the microsatellite stable, and 60% in the microsatellite high non-colorectal cancer. And as you can see here in this Kaplan-Meier curve, patients with a mismatch repair deficiency compared to the mismatch repair proficient also had a benefit in overall survival. Therefore, mismatch repair analysis turned out to be an agnostic marker to treat patients with immunotherapy regardless of the tumor origin. This has evolved in first-line treatment of patients with advanced colorectal cancer and microsatellite instability or loss of expression of the proteins, when this phase 3 clinical trial that compared pembrolizumab to investigator choice of chemotherapy showed that the progression-free survivals in patients treated with pembrolizumab compared to chemotherapy also supported a decrease of progression or death with a hazard ratio of 0.60 and improving from 8 to 16 the median time of progression-free survival. Very recently, just a couple of weeks ago, it was this paper was published along with a presentation in ASCO, in American Society of Clinical Oncology, of patients who had locally advanced rectal cancer and mismatch repair deficient tumor and were treated with a PD-1 blockade with dostarlimab. 12 out of these 16 patients completed therapy, and 6 actually had a very long follow-up, and they all achieved 100% clinical complete response only with the treatment of dostarlimab. The majority of these patients had Lynch syndrome, and you can see here very well the nice response to immunotherapy in patients with mismatch repair deficiency. So going back to the family history again, the patient had the germline mutation, and this allowed to perform predictive testing in his family members. His father was found to be an obligated carrier. His brother was MSH6 negative. Here, his aunt was also MSH6 positive. His cousins, one of them was positive, the other negative. And also here, you can see how cascade testing was performed, which allowed to identify patients at high risk of developing colorectal and endometrial cancer, and also those who could spare this intensive screening. Because what we know so far is that patients with MSH6 mutations approximately might have an estimation of 20% risk of developing colorectal cancer along their life. Women may also have a higher risk of developing endometrial cancer, 41%, and 10% of ovarian cancer. In terms of surveillance recommendations, there are different societies providing different recommendations. They more or less match between them quite well. In terms of screening for colorectum, colonoscopy is being recommended, starting at age 25 for MNH1, MSH6, and maybe a little bit later for MSH6 and PMS2 between 30 or 35, with intervals between 1 and 2 years. The uterus is also being recommended to be followed up with transvaginal ultrasound plus minus endometrial biopsy starting at the age of 30, 35, ovarian screening, and then in some cases, and according to family history, perform upper gastroendoscopy and follow up of urinary or kidney cancer according to family history. So in conclusion of my talk, what I wanted to share with you is that tumors with MSI high or loss of expression of mismatch repair proteins are candidates for a germline genetic evaluation, regardless of the type of tumor or family history, since approximately 1 out of 6 might have a Lynch syndrome. This is a hereditary cancer susceptibility caused by germline alterations in the mismatch repair genes. that made this tumor sensitive to PD-1 blockade, and identification of Lynch syndrome through a patient with cancer for a therapeutic indication may also allow to do cascade testing in their relatives, and this will also provide a tool and a motivation to start cancer surveillance in carriers and spare the follow-up in non-carriers. And with this, I want to thank you all for your attention, and I'm happy to take any questions. Thank you.
Hi, Judith. Can you see me?
Hello. Yes, I can see you very well.
This is your present. We will send it by post.
Pick it.
Okay, pick it.
Thank you.
So, first thing we learned, Lynch syndrome can do any cancer, basically. I've also seen sarcomas in patients. And one question from my side is, the microsatellite instability was the molecular testing of microsatellite repeats. And
Correct.
And because in immunohistochemistry, was that more sensitive for picking MSI high or microsatellite instability testing? What I got from your talk is that immunohistochemistry might have been more sensitive.
Regarding the series from the memorial, the fact that it was a pan-cancer analysis probably made immunohistochemistry more sensitive than MSI, considering that the biomarkers for MSI analysis are the ones that were developed and validated mostly in colorectal cancer. So I think that one of the lessons we have learned when doing pan-cancer analysis is that loss of expression of proteins might help to identify. But this might also not be accurate enough. I think from our clinical case, there are still some lessons to learn. So we haven't performed tumor sequencing, for instance, and so we think there is a biallelic inactivation. Otherwise, we wouldn't have this loss of expression of MSH6. But having a functional defect would be at the end the best biomarker for immunotherapy.
Yeah, here in Germany, we basically do immunohistochemistry testing and not so much molecular testing. But really, I think it's fairly sensitive if it's done properly and the antibodies are working like the ones for PMS2, which are a little tricky. And the thing we learned is that one should always consider Lynch syndrome behind MS or behind any loss of mismatch repair proteins. Are there any questions from the audience? It's a little difficult from... Yeah, no, there are no questions. So due to time reasons, Judith, many thanks from Munich, many greetings, a little sunshine, which you probably have yourself in Barcelona. And
it's quite warm.
Yeah, many thanks for taking part, and hopefully next time we can make it in person. Thank you,
Sure.
Judith.
Thank you very much
for
the invitation.
Bye-bye.
Bye.